Okay, the meeting's live now, Chair.
Thank you very much, Jane. Right, I would like to welcome everyone to our Portsmouth CCG Governing Board meeting in public. I'm Dr. Elizabeth Fellows, Chair of the Governing Board. We're meeting virtually in response to limitations placed on governance by the COVID pandemic. Members of the public have been invited to view this meeting via a link available from the CCG website. Papers for the meeting are also available on the CCG website. Today's meeting is being recorded so that in the event of a technology failure, it can continue and will be uploaded to the website as soon as possible. Bookmarks have been added to the pack of papers in order to identify the agenda items. Members, you are asked to keep your cameras on where possible, but mute your microphones unless you're called to speak. Please only use the raised hands for indicating you wish to speak, and preferably avoid using the chat because I find that very difficult to police while sharing as well. And any comments in the chat can't be viewed by the public. So I'll ask you in turn to state your name and role title in order to confirm your attendance. So starting with Maggie, please.
Good afternoon. Yes, I'm Maggie McIsaac. I'm the Accountable Officer for the CCG, and I'm also the ICS Chief Exec Designate for Hampshire and Isle of Wight.
Karen?
Yeah, hi Elizabeth. I'm the Governing Board Nurse for Portsmouth CCG.
Linda?
Hi, I'm Dr. Linda Colley, local GP and Clinical Leader for Health and Care Portsmouth.
Margaret?
Hello, I'm Margaret Geary. I'm the LA member with Portsmouth CCG.
Sarah?
Hi, Sarah Daly. I'm the Director of Children, Families and Education.
Austin?
My name is Carsten Shaft. I'm a local GP and I'm one of the clinical execs at Portsmouth CCG.
Graham?
Afternoon, everyone. I'm Graham Love and I'm one of the lay members with Portsmouth CCG.
Jackie?
Hello, I'm Jackie Powell, another one of the lay members for Portsmouth CCG. Thank you.
Simon?
Hi there, I'm Simon Simonian. I'm a GP and one of the clinical execs.
Michelle?
Hi, I'm Michelle Spandley. I'm Chief Finance Officer for Portsmouth CCG.
I don't think Tawinda has arrived, has he? No. David?
Hello, everybody. David Williams, Chief Executive, Portsmouth City Council.
Joe?
I'm Jo, your Managing Director for the CCG.
And then we have some people who are presenting papers today, and I think most of them are on the call already, which is very kind of them. So Bernie?
Hi, I'm Bernie Allen, Deputy Director of Planning and Analytics, and we'll be presenting the paper on performance.
Thank you. Nikki?
I will definitely be saying it's one of the best.
Oops. Right, so we've got...
Oh, sorry.
Are you coming in, Nikki?
Oh, can you hear me now? Yeah, so I'm Nikki Burnett, I'm Deputy CFO.
We've got Jane Collis, who is our Business Development Manager, taking our minutes. Justina?
Good afternoon, I'm Justina Jeffs, Head of Governance for the CCG.
Making sure we stay on the straight and narrow, thank you. And then welcome to Matt as well, who's presenting a paper.
Thanks, Elizabeth. Matt Gummerson, Strategic Lead for Intelligence and Public Health, presenting an update on COVID-19 data.
Lovely, thank you. And then we've got formal apologies from Andy Sylvester, lay member, and Helen Atkinson, Director of Public Health at the City Council. And we are still missing Tawinda, and hopefully he will join us shortly. So welcome, and let's move into our formal agenda, starting with the register and declarations of interest. Has anyone else got any updates for the declarations of interest? Simon?
Just to say, my declaration is up to date, but I think this has got a slightly older version just because I'm no longer a salaried GP at Lake Road.
Right, so we need to update that. Thank you.
Thank you.
And mine needs to be updated because I am no longer a partner at Eastshore Partnership, but I'm now a salaried doctor there. My last swan song, which I think means also I don't have a direct interest in the PPCA, Portsmouth Primary Care Alliance, but we'll double check that. But I think as salaried, it doesn't impact on me, but we will sort that one out. So we'll get that updated. Anyone else, any updates? And any declarations of interest not previously declared for this meeting? Lovely. Thank you very much. So we will move into the minutes of the previous meeting. Does anyone have any comments or corrections in the first instance on these meeting notes, minutes? Jackie's shaking her head, so that's a good sign. I'm just wondering. No, Maggie's talking to someone else. Right. So are people happy to accept these and approve these meeting minutes?
Yep.
Lovely. Thank you. And we need to note progress against the agreed actions. So, summary of actions, item 3B. So those are noted. Yes, so the elective hub strategic outline case is in the executive report, I believe. Is that?
Yeah, it was in the electives report last time.
Last time, so that's in the
wasn't it?
wrong
Yeah.
place, isn't it?
Yeah.
I was thinking we've had that discussed.
Yeah.
Right. So sorry, we need to get that sorted. Jackie.
Thank you. I was looking at 3A above, which is about the care home, and although it's noted in our pack today that the care home remains inadequate, I just wondered if there was any more that could be done to make sure that the people that are within that care home are being treated safely and appropriately, or there are other kind of processes in place to ensure their safeguarding and such like.
Karen, are you able to update us?
I do know that the quality and safeguarding team are working quite closely with the home and with CQC. I don't know how many Portsmouth people we have actually in the home still. I don't think it's full to capacity, but I do know that there's a programme of work ongoing, and the quality and safeguarding team are involved in that, Jackie.
Okay, so it kind of satisfied that those that are there are being treated well and safely and protected and that sort of thing.
Yeah, yes, so they're still working to make improvements, but
thank you.
Yeah, and I have to say, are we on the right thing here? Because these are the summary of actions from February. We only did a development session in March, didn't we? That's where we're adrift.
Yeah.
Right, David, did you want to come in? Yeah. Okay. Lovely. Thank you for that. So moving on to our Health and Care Portsmouth COVID-19 update, and Matt Gummerson is here to do this for us.
Thank you, Chair. I shall share my slides on screen. These can be sent around after the meeting, so you've got access to these. This is a brief summary of where we are currently at in terms of COVID-19. I'll try and explain some of the changes that have happened in terms of what data is reported since you last met, but there have been a lot of changes as we moved into the living with COVID phase of the government strategy. So as a result of that, obviously with the end of universal free testing, the availability of data in terms of positive cases has changed significantly. So we now increasingly use the ONS infection survey as our kind of gold standard of what's happening with COVID-19. As this is a national survey using a random sample of people that have been tested every week since the start of the pandemic, and provides detailed breakdown by age as well as by region. But on here, you've just got the main headlines. It does give us a really reliable indication of how much COVID is around, but does come with a bit of a lag in terms of time. So this data was released on Thursday and goes up to the end of 9th of April. As of that week, they estimated just under 7% of the population would have tested positive that week, around 1 in 14 people, so very high rates of COVID prevalence. The chart on the bottom left-hand side shows that it has come down from where it was in the previous week and the week before that. So it looks like we've gone past the peak, which is good. However, worth noting that there is still incredibly high rates, that's as high as at any point outside of the most recent couple of weeks of any point during the pandemic. Slightly lower in the southeast. So on the right-hand side, you see it's come down to around about 1 in 16 people in our region. They do produce data at a more local level, so we've included the Portsmouth data within that. They estimate 7% of the Portsmouth population. The chart on the top left-hand side shows where we're distributed across the different areas that they model it at, not all upper tier local authority level. But broadly speaking, you can see we're in the kind of bottom half of that distribution, but very wide confidence intervals on that model data. So I would take it with a pinch of salt. I think the regional data gives you a good indication of what's happening. In terms of the recorded cases that are still reported on the national dashboard, a very different picture. So the bottom left-hand chart is the positive cases, and you can see on that those numbers have come down significantly from the most recent peak and indeed from the points earlier in the year, but that largely reflects the right-hand chart, which is the decline in the numbers of tests being carried out. So much fewer tests being carried out, so fewer cases being identified. The middle two charts show the deaths within 28 days of positive test and patients admitted to hospital, both of which also look like they've just reached the peak nationally, which is positive. And nationally, 92% of people had their first dose, down to 68% for boosters or third doses. In terms of our local case data, again, that's following a similar trend. So it has come down. Up to the end of last week, we'd had just over 1,000 reported infections in the most recent week, down to an average of around 142 a day over the last 7 days. So down considerably again on the peaks that we were at a few weeks ago and indeed earlier in January this year. But still, even with that decline in testing, compared to similar levels to where we were at in the autumn this year, and indeed where we've been broadly since the easing restrictions last summer. So there is still a lot of COVID being recorded. The rates, the 7-day rates per 100,000, the table on the right-hand side, again, just give you a sense of the decline week on week in most local authorities and indeed the southeast region, down 30% as a whole, in England similar. The map on the left-hand side now uses just Pillar 1 testing. So again, one of the most recent changes is they're no longer using Pillar 1 and Pillar 2 testing for lots of the recording, Pillar 2 being LFDs predominantly. Pillar 1 is mainly tests carried out in NHS settings. So it gives a slightly different picture to what we've previously reported, but gives you an idea of the geographical areas that are still seeing those highest rates, so southwest areas in the north and northwest. But broadly declining rates across the whole country, which is encouraging. And then our local data, so this is our 7-day rates per 100,000 broken down into 15-year age bands. And again, goes over the whole course of the pandemic, so you can see the different waves travelling through at different time periods. But the most recent data on the right-hand side shows we've seen consistent falls since late March across all age bands. A bit of fluctuation in the red line there, the over 75s rate, but that has encouragingly come down in the last week or so. So we're seeing fairly low rates now in most, or relatively low rates in most age groups, and a consistent fall, which is positive. In terms of the data for Portsmouth Hospitals Trust on COVID admissions, so the chart on the bottom shows again the whole course of the pandemic, and you can see that COVID admissions are at high levels and have been increasing since the autumn, and continue to increase until the most recent week. The inset data on the top right shows the most recent data covering the Easter weekend from Portsmouth hospitals. This is not just Portsmouth City Council or CCG populations, it's the whole of the hospital trust catchment. Does appear that new inpatient diagnoses and COVID admissions have begun to decline over the last week or so. But obviously a bit of unwinding of the bank holiday weekend data still to be seen, and some gaps in reporting causing that big drop on the 18th of February. So we'll wait for the rest of the week to see how that plays out. But hopefully we've passed the peak now in terms of new COVID admissions at the trust. But obviously there's still significant numbers, as you can see on the data on the top left there, 230 or so patients in QA with COVID at the moment. In terms of vaccinations, it's not huge changes over recent weeks in terms of the vaccination numbers, some changes in the methodology that will reduce the percentage a little bit, but we're around about 80% first doses, 75% second doses, and nearly 58% of people eligible, people aged over 12 know they've had their third or booster dose. It's around 80% of those that are eligible for a third or booster dose have had their booster. And those numbers are kind of have been, let's say, fairly stable for a while now. And in terms of deaths, we've had 7 deaths in the last 7 days in Portsmouth and 28 days of a positive COVID test. And again, it's at a level that's been fairly consistent throughout the Omicron wave, at least. Encouraging though, we're still seeing fewer deaths than we'd see each week in a typical week. So the bars along the bottom represent the most recent week's data on the right-hand side. This is all deaths in Portsmouth. The red bits of the bars are COVID-related deaths, and the green diamonds above them represent the average number of deaths in the equivalent week across 2015 to 19. So you can see there that for most of 2022, we've been seeing fewer deaths each week than we would see in a typical week at this time of year. Largely, I think, accounted for by the fact that the average that we're using 2015 to 19 includes 2018, which was a fairly bad flu year, and we're still really not seeing any flu around at the moment. And that's all of my data. Happy to take questions on any of that if you have any.
Thank you very much, Matt. That's really useful. Karen.
Just a quick question, Matt. Thank you. You said we got 230 admissions at the moment, COVID admissions. Are they people that were admitted because of COVID, or were they admitted and then tested and found to have COVID?
Yes, that's 250 patients currently, or 230 currently occupying beds at PHU that have got a positive COVID diagnosis. They won't all have been admitted with COVID. Lots of them will have been, a proportion will have been admitted with COVID. Some will have been identified when tested at the hospital, and then some of them will have picked up their infections nosocomially. But yeah, okay, so it's by no means all admissions.
Jackie.
Hi, Matt. I was looking at our performance data, and for COVID vaccinations, I was really surprised. It's RAG rated red. Still says 83% of COVID percentage of adults vaccinated. It's 83%, but RAG rated red with a target of 90%. I always thought we were doing fairly well with our vaccinations. Is there a concern, or is there more that we can be doing?
I'm not sure where the target in your specific data will have come from, but I think broadly we're around about where we would expect to be given the demographics of our population. So there are nationally there are higher rates in less deprived areas. There are higher rates of vaccination uptake in areas with older populations. So we're broadly similar to comparable areas. So I don't think from our point of view there's any particular cause for concern. But obviously anything we can do to get that 80% up to 90%, or we need as close to 100% as possible, would be beneficial.
Thank you. I see Bernie's got her hand up, so I'm guessing she wanted to add to that. Oh, Joe, and Joe as well.
I was going to say it was Joe and then Bernie.
I'll let Bernie go first. She's probably going to say what I was going to say.
So the targets from NHSEI, it was their kind of optimal target for the nation in terms of providing some coverage. As Matt says, our current compliance rates are consistent with demographics of populations like ours. So that's kind of the measure. In terms of the current admissions to PHU, about 20% of them have been admitted for treatment primarily for COVID, and that proportion has been consistent throughout the last wave.
That's really useful, thank you.
Yeah, so
I
do
had
you
a
think
feeling it was that sort of level. Jackie, did you want to come back in?
I was just going to say, so when we rag rate it red, are we doing ourselves a bit of a disservice? I'll let Jo come in. There may not be an answer. There may not be an answer. There may not be an answer.
Yeah, so obviously these are the NHSEI targets, and we, you know, we rag rate ourselves depending on how far we are against the target. I think for 80%, as we said, we've got quite a small percentage of people who are those hard to reach groups who perhaps we have struggled to convince around the vaccination and the offer. There's been a huge amount of work ongoing really around that, and very close working with the public health teams and Solent, pop-up clinics, you know, clinics in various places. And as you know, we've done really great work in the sort of the outreach to the homeless and the vulnerable communities. So it's really a sort of a core group that perhaps are reluctant to take up the vaccine, but we continue to work with those groups and look at how we can try and increase uptake in that group. But we've had some real success, as I say, with the homeless, with the frail elderly, with learning disabilities clients, some of those more vulnerable groups, and the uptake is lower in some of the younger age groups as well. That's where there's been perhaps some resistance, but again, I think that's quite common. We're not an outlier by any stretch of the imagination.
Thank you very much, that's really helpful.
Did you have anything else to say, Jackie? Lovely. So are there any other questions from Matt or Matt? Great. Well, thank you very much, Matt, for coming to present that data. It's really useful. And we are definitely at a very tricky time with the loss of the national testing programme. It does feel quite unnerving not knowing. And there's certainly plenty, as you say, of COVID still around. But thank you very much for coming. That's great. So I would like to move on to item 5, which is the executive report, and over to Jo.
Thank you, Elizabeth. Just to say, this is the standard report where we provide an update of the work of the executive team and the committees of the board. So this month we focused on the work of the Quality and Safeguarding Committee. It's been quite a big piece of work around the primary care quality report that they reviewed, and also the CQC report from SCAS as well. Similarly, we've got some information on the Primary Care Commissioning Committee, and the update from the Remuneration Committee, which was meeting with regard to the extension of the CCG. As you know, originally the ICS was due to come into being from the 1st of April, and that's been delayed until the 1st of July. So as a Remuneration Committee and as a board, we had to look at making sure we could continue to operate for those existing 3 months, and some HR processes undertaken to support that. Looking more broadly, we've provided an update around the COVID-19 inquiry, and Baroness Heather Hallett, DBE, was appointed as the inquiry chair in December 2021. The consultation around the terms of reference completed on the 7th of April, and we're just waiting for those terms of reference to be published and shared with us. We have set up across Hampshire and the Isle of Wight a COVID-19 inquiry working group. We don't know if we will be an area picked, but we are looking what the possible requirements of the inquiry to ensure that we are prepared should we be required to provide evidence as part of that committee. Apologies for the dogs. And then we've also, again, the National Information, the Ogden report has been released recently, and we've got a presentation on that a bit later on in the meeting today. And then the other update from this report is some more detail around our integrated Health and Care Portsmouth communication and engagement team and the work they've been doing to support primary care, and in particularly urgent and emergency care, but also around the vaccination and some home care recruitment to support domiciliary care for adult services as well. And as well, also the work they've been doing to support us into the transition into the ICS and the ICB. So any questions really on the report?
Lots of shaking of heads. I think it's a nice detailed report and everyone's happy with that. So we're being asked to receive that report, which I think we've duly done. So we are cracking on through this agenda. On to systems update, and if we can start with Maggie with the ICS update. Please.
Yes, thank you very much. I just want to bring you up to speed with the various facets of the integrated care system development, and as Joe's already said, the delay, but the likely go ahead for July now, still subject to the legislative process. Things are changing quite quickly in terms of feedback from that process, and what we will be doing, and the timing just didn't work, there will be a briefing note that will go to all the boards in Hampshire and Isle of Wight very shortly, so we will get you that, and that will look out for that because that will be the latest position, so that should be coming out very shortly. So if I just run through some of the areas. So first of all, just wanted to talk a little bit about staff engagement, staff and partner engagement, because as always, when you go through a process of change, it can be really worrying for staff. So Joe and the team working really closely with all our staff, you know, recognising people aren't together as much as they would have been pre-COVID. So just trying to really make sure that we do that well, given people are working in a hybrid fashion. We've got a staff platform called Stay Connected, which is one of, not the only way, but one way to try and get consistent messages out to people across the whole of Hampshire and Isle of Wight. Very pleased that the Portsmouth team are now able to log on to that and be a very active part of that. And certainly separately to this, I know Joe will very happy to help anybody who doesn't quite know how to do it, and there's technical help to do that, but hopefully that will help. So as things change, it's a definitive source of information. It also has a softer side and gives people updates on other things that are going on, and has the potential, which we're now exploiting, to do place-based updates. So if you're in the north of the county, you perhaps don't need to know the detail of what's happening in Southampton or Portsmouth and so on. So we'll continue to use that tool in addition to local mechanisms. So that's a little bit about comms and engagement. The next bit is the formal piece, and that is the formal process of TUPEing our staff over to the formal integrated care board on the 1st of July. And as you know, we need to go through a formal TUPE consultation, and Joe and the team working really closely so that we do this at the same time, so that everybody has the same experience. Again, it's a very relatively simple process. People are TUPE'd over, and from the 1st of April, people's pay slips will be Hampshire and Isle of Wight Integrated Care Board. But again, these things are always concerning for staff, so lots of reassurance there that this affects everybody and everybody's posts, whether they're joint funded, joint appointments or sole funded, will be affected. So that is progressing, and as part of that, there are lots of opportunities for drop-ins and people to talk to people about what it means for them. But certainly anybody who has been through similar events like this in the history of the NHS will know that it is relatively technical and smooth, but we just need to make sure that it is that and that people understand that and aren't worried. And as you know, there is an employment protection for all staff as a result of this change, which is different to some of the previous reforms. So our staff should be confident that the thing that will change on the 1st of July, subject to legislation obviously, is the pay slip will change, but their work, their teams, their communications, all of that will stay the same. So that's the TUPE process, and when I finish, Joe might just want to come in with a little bit more detail on how that's going. So that's the TUPE process. The next thing that is due in later this week is the Integrated Care Board's constitution, and this is part of the formal ICS development programme, various milestones where various documents and process has to be submitted nationally, as you'd expect. And the next cut-off point is this April. So there are lots of very active conversations with everybody, really, all the partner groups, everybody who's involved, so that the constitution is as best as we can. And the thing that may change after April is there may be some national changes as a result of the legislation process, and obviously that might require some more changes. So we'll keep everybody posted as all this iterates, and once the document is ready for Friday again, it'll be really important that we get that round to everybody and you can see where that lands. Just the final thing to say about that is that it doesn't always feel like it, but the feel behind these changes are to really not to top down from national, but to give permissions and allow flexibilities. So perhaps unlike other constitutions, you won't see massive finite detail about everybody on every committee and all the detail, because if you do that, and we in Hampshire and Isle of Wight and in our places and our geographies need to change it, then you have to go through this very complex process of getting the constitution changed. So this is genuinely giving us more flexibilities than perhaps we've had before, and I think it's just really important to remember that that the steer from the centre is to only put some things in legislation and to give us freedoms. So what things actually look like and who's on committees and all that kind of thing, there will be some flexibility, which I think is to be really welcomed. The Integrated Care Board and its membership is very live, very active discussions and appointments going on at the moment. So first thing to let you know is by the end of this month, so by the end of April, we should be in a position to have made some non-exec director appointments, and that process is ongoing at the moment. There have been 2 sets of interview dates, and the final conclusions from that process should be coming through in the next few days. So by the end of April, we should have some NED appointments. Also, executive appointments are progressing as well at the same time. So by the end of April, if not all, but we should have some of the execs and the non-exec appointments. The other group of appointments for the ICB are so-called partner members. So partner members are full active members of the unified board. So they're not people who represent and come along. They are absolutely full members of the board, and the partner organisations come from 3 groups. First of all, primary care, secondly, NHS providers, and thirdly, our local authorities. And there's some detailed work with all those various groups at the moment, ascertaining the number of appointments, the process of nomination, followed by the process of selection. So that's very live at the moment, very active, and we'll work that through. Nationally, we have been told that that process needs to start after the 6th of May, so after local elections. So we've got a little bit more time and very active conversations with the primary care network community, with local authorities, and with our NHS provider organisations. So we'll keep you really posted on how that's looking, and there's all kinds of guidance coming to help us through that, and we'll abide by that, but we'll listen to our constituent organisations and do the right thing for Hampshire and Isle of Wight, recognising other ICBs are either smaller or bigger and they've got different geographies for place. So we're trying to do this in the right way for us, but very active moving feast at the moment. So that's the board membership. The next really important piece to do more work on now, once that is sorted, is place. And what does place mean? How is that governed? Our absolute commitment is to really value place and make sure that decisions are taken locally, as much resource as possible gets to place, and we make this an easy thing to do, because this is not trying to pull everything back to our Hampshire and Isle of Wight, it is trying to recognise place. So there are various focus groups, lots of people involved in what this looks like. It doesn't have to look the same in every of our geographies. So we'll be working all that through in some real detail over this period. It doesn't all have to be in place by the 1st of July, but I think we're hopeful between us we'll get enough. And then the deadlines nationally on place are actually next year, but I'm very confident, particularly in Portsmouth, that we can be really ahead of this and use this period to follow the work of Portsmouth Health and Care and really build that up. So that is all progressing, and we'll work that through. And at the same time, our provider collaboratives, where we work in the geographies around our hospitals, that work is progressing. So Portsmouth and South East. So trying to further, if you like, codify what each one does and how each one relates to each other is some detailed work that we will be working through. The other thing just to mention at this time is later in May, the Fuller stock take will be published. So this is Dr. Claire Fuller, who is a colleague of ours in Surrey and is also the accountable officer for the Surrey CCGs and has just been appointed as the ICS lead. And Claire's been asked to lead a team nationally to review primary care. So it's not the contract element of it, because the current contract goes on until 2024, but it is the role and contribution and voice of primary care. And it's probably a whole topic for another time, but how important primary care is, general practice, PCNs, their role and contribution, their voice locally, but their voice in all of the work that we do. And I think we will find that report really helpful. I know a lot of our clinicians have been involved and have contributed via Twitter, via webinars and via submissions. So that work will be really important and will be really for us to able to work through that in much more detail. And again, Linda might want to say something about that. So that's our agenda coming forward. And then the final bit of the jigsaw of the integrated care system is the integrated care partnership. So this is a statutory committee that is formally to be convened between the local authorities, the upper tier local authorities, with the integrated care board. So less formal work has been done on that, but a plan is in place for Lena Samuels and the team to be working with the 4 local authorities to work out what that board is, how it works. It's certainly envisaged that across Hampshire and Isle of Wight, that is the place where there'll be broad involvement, Health Watch, Fire and Police, academic health science networks, academic institutions, etc. So that really is the wider place where the strategy will all be about health and well-being, improvement in outcomes from a wider perspective, but working that through and who sits on the actual committee versus who's involved in a much broader way is what we will be working through. So good progress. The team are keeping really close on what's changing nationally. Lots of work in each of our geographies, each of our systems, and we will particularly of the rest of April, May, June, pieced together so that we are safe for July, that there is a safe transfer of all our responsibilities. We look after our people, and then the development agenda will continue through 22-23. So I'll stop there. Linda and Joe might want to come in with a bit more detail. That might be helpful. And as I say, there will be a written brief of this with all the latest once the deadline, once the submission has gone in on the 22nd. So thank you.
Thank you very much, Maggie. So Linda and Joe, do you want to add anything?
Only to say really that clinical conversations are very live about how we're going to be represented across the piece and what we're going to do together and what we're not. You know, trying to get clinical cabinets, etc., properly established across. And I think it's really important it is going to be those groups underneath and how they feed up to the ICB is going to be critical really, and getting the right people at those groups. Rather than focusing on who's going to be just the one seat at the board. I think that, you know, the clinical conversation is going to be much more live across the piece than that.
Thank you. Joe?
Yeah, just to add around the safe transfer, all of that work is ongoing through the due diligence, the various work streams, the governance and the finance work streams. Some of that can't take place until much closer, but obviously, as Maggie said, the GP is underway. So the letters went out to all staff yesterday, and they're on Stay Connected and on our intranet. There's a number of staff briefings, and there's an all staff briefing. I think it's next week on the 27th, where our CCG staff will come together with Hampshire, Southampton and Isle of Wight CCG staff as well. So we're all hearing the same information. And then lots of other opportunities for staff to comment and be involved. And our staff engagement group were very involved in the development of the letters and the frequently asked questions as well, as were other staff engagement groups across the piece.
Lovely, thank you. We've got Jackie and then Margaret.
Yeah, I hope mine is sort of relatively straightforward. On the Integrated Care Board, we would like, I think Linda's spoken for primary care and the possibilities of that. In terms of local authority representation, do we have a sense of how that's going to be? And then how the Integrated Care Board clicks in with the provider board? Have we got any sense of what that might look like? That's a general question. I don't know who's got the answer.
Shall I start? And I'm sure David will want to come in. So on local authorities, as you know, the formal requirement is one local authority member, and that just doesn't feel right for our kind of geography with the complexity of unitaries, the county, districts, rural cities. It doesn't feel right. It's a bit like Linda saying, it's hard because everybody wants to be at that board at the moment, and I think they probably will do so until we've further defined the other mechanisms where actually things will happen, be it at place or be it in the clinical cabinet or in various other work groups. So it's fair to say that we're in very active dialogue, ranging from everybody has a place through to a number of places, and Lena Samuels is holding that space. So at the moment we've got a proposition out to the local authorities about the number of places which are open to officers and elected members, and we're going through that conversation, and you know, I'm really confident we'll get to a place where, you know, we'll have good representation with, you know, 9 districts, and for, you know, there's a lot of people, and obviously everybody can't be there, but I think everybody's really minded to work together. The other thing just to say, and this might end up being one of the things we have to do, but it is really good practice. Lena will be really keen to be looking at her whole board and looking at the skills and perspectives and experience, so that it's really balanced in terms of equality and diversity, but really balanced in terms of experience and perspective, so that accidentally through partner nominations you don't end up with a lot of people who all are very similar, that we bring the richness and we bring the diversity, which, you know, genuinely we all believe that will get us to better decisions. So it's quite a complex board to run as we try to balance the appointments and the partner members and bring it all together and then get that board working together as a new unitary board. So shall I stop there, and I'm sure others will want to come in.
I was wondering if David would like to come back in, because I know you've been very involved in those discussions.
Yeah, as Maggie says, those discussions are still going on. In fact, I've got a meeting. I've been having meetings this week with the other local authorities, and on Friday I should be meeting with the leaders of the local authorities as well, just to try to make sure that strong representation is possible on the board. And I think, yeah, it is difficult trying to do it at this stage, because until we really know how the thing's going to operate and how all the parts are going to work together, it does leave people feeling a bit anxious sometimes. I'm hopeful that we'll be able to come to an agreement. I think, yes, it will be complicated by then there being a desire to get balance in terms of other criteria across that board, and we'll have to see how that plays through. And Maggie and Lena and I have had conversations about the positive vetting proposals and how well they're likely to go down with directly elected members. I think the other point is that as I understand it, there's a requirement or a desire to send in the constitution by the 22nd, i.e. end of this week. The last version of that I saw, I don't think made it clear that they were minima in terms of representation on the board, and I'm assuming that will be made clear because we don't yet have agreement. But certainly there's good dialogue going on. I'm sure the local authorities will be able to sort themselves out. I think the complication will be then trying to sort out that cohort with the other cohorts that have either already been appointed to the board, are direct nominations to the board, or are elsewhere in the process. Thank you.
Thank you. Jackie, did you want to come back in on that?
Yeah, I can hear how complex it is. And you're right. I think it's about, until you know what the rest of the shape is, it's very difficult for people to feel comfortable, because this might feel like the only opportunities. But I'm really hoping that is not going to be the case. But I was also curious about then the bridge to the integrated care partnership, because I suspect that could be quite a significant platform, and I'm not sure how those two come together or operate. But that might be a question for another time. I'm happy to.
No, it's a great question and needs working through. It is the place which is broader. It is formally a joint committee, and the detail of how that works is subject to some work stream. And there is a really practical thing: that is there a board of that, and if so, is it anybody and all members, or is it a smaller board formally? Because really this is the place where we would want to have a very wide inclusion. So all of that needs working through so that people feel more comfortable. And I think, as we've all said, I think as we get place, provider collaboratives, the ICP, the ICB, as all of them develop, people will feel more comfortable with understanding how it all fits together, how voices are heard, how things are delegated, so I think we're at a moment in time when we just have to keep on going. And of course, I mean, one of the things that we may want to do, and Lena will be considering this, is, normally at times like this, one would appoint everybody for, I don't know, a period of 3 years or something. A way through this might be to do a mix of appointments, so that everybody doesn't change at the same time, but it also allows you to kind of flex, take the strengths, build transition, through to a future state. So we'll keep an eye on all of this. And as I say, I think it's really important now that on a regular basis, everybody can see the timelines, but also the progress for each of these parts, not just the ICB, which is probably where, understandably, where a lot of people's focus has wanted to be, out of a positive sense of wanting to contribute. But as Linda said, I think in reality, we'll find that a lot of people in the end will find their contribution in different places, but making sure, just coming back to primary care, we want that strong GP primary care voice throughout. We want it locally, we want it in neighbourhoods, but we want it in work streams, and we want it across the piece. And that's one of the things that Linda's working very closely with Nicola and Derek Sanderman, so that it's about really strong voice in all the spaces and places, and making it sensible and joined up. So lots more to do, lots more to share with other ICSs, lots more to find out what other ICSs are doing. But at the end of the day, we need to make this work for us, because this, it's an opportunity.
Thank you.
Lovely, thank you. Thank you very much for that comprehensive update. It's been very useful, I think, and we will take part in those further onward discussions and continue to shape it. So thank you very much, Maggie. And so David, and the Health and Care Portsmouth update.
Yeah, thank you. And I guess this follows on really from what Maggie's been saying, because the thrust of our work has been to make sure that as the place, we're in the strongest possible position and fittest form to play a full role within the new system. So we've been developing new work around the Section 75 agreement, which allows the sharing and pooling of funds. That work has been going very well. At the moment, we have 3 Section 75s, one around continuing healthcare, Better Care Fund, and then the Health and Care Portsmouth commissioning strand. We're broadening that. We think that we will have 6 contributory strands within the new Section 75 agreement. And just to give you some idea in terms of the scale, I think that the previous Section 75 agreement covered about 100 million in spend. That's both the CCG and Portsmouth City Council. What we've agreed with the Cabinet and Council at Portsmouth is that just the council side of that will go up to something in the region of 160, 170 million. So that just gives you an idea of, it's not just the breadth of that engagement, but it's also the quantum. I think the breadth is really important from a symbolic point of view as well as the actuality, because I think it demonstrates the commitment to the wider determinants of health. I think it really does demonstrate the significance of the children and young people's agenda, as well as the adult and the elderly agenda. Similarly, public health, but also the sort of almost the backroom side of it as well, in terms of including funding. Then I think it's nearly £1 million that will help the transaction side of it and the joint working. So what we're focusing on is making sure that as Portsmouth, the place under the umbrella of Health and Care Portsmouth, will be in the best possible position to fulfill the aspiration that Maggie's outlined, that we have as much delegation to place as we can possibly secure. Other things that we're doing to that end as well, we had a meeting of the Joint Commissioning Board last week, and we are looking at addressing the constitution of that board again, so that it's in a fit state to slot into the new system and enable that delegation to place to be fully facilitated. Other things that have been going on, there's been quite a bit of progress on the joint work that we've been doing with other public service partners, including the NHS, but also police, fire and rescue around the estate up at Cosham. That's been going well. And I guess the other bit of the jigsaw is just making sure that where we do have in place Section 113 arrangements with individual members of staff, whether they're NHS, local authority, which bit of the NHS, I know we've got some with Solent as well, just to make sure that everything's in place there as well to enable full delegation to place. So I think that's really a summary of where we've got to. Thank you. Happy to answer any questions.
Thank you. Margaret.
Mine really is straightforward. I appreciate greatly and actually think it's been really good, the progress that's been made, both at the kind of ICB, ICP, etc. levels and at the level of place. And both involve quite a lot of complexity, I think, in terms of just sorting out the different strands and making sure they're properly aligned, etc. One of the questions in my head is, where do health and wellbeing boards fit now? Because they will presumably still be statutory bodies in each of the places. Just a question.
Yeah, and certainly, I mean, from our point of view, in Portsmouth, the Health and Wellbeing Board will be absolutely fundamental. It will be to that and its strategy that the Health and Care Portsmouth work will want to align. It will still have a responsibility for commissioning and signing off the JSNA, which will be the fundamental building block of so much of what we do. So I guess all of these elements are we're just trying to make sure that we've got all of those building blocks in place, ready to go. For example, the City Council has delegated to me authority to sign the Section 75 agreement, so that there's no hold up there. That won't need to go back through the political process in any way. Whether we need anything similar from the CCG's point of view, I don't know, but I think we're just making sure that any impediments are out of the way, and that we've got the tools that we need to function effectively at place.
And is that reflected in other places across Hampshire Isle of Wight? There's a question, isn't there, for the wider ICB about, and ICP in particular, maybe about the relationship between health and wellbeing boards and local.
Yeah, Maggie, can you come in on that point?
Yeah, I mean, as you would expect, really, everywhere, excuse the pun, is in a different place, and that's just normal and natural, and different factors in different places. In some other places, there's been quite a change in people, not in Portsmouth, and that has an impact. So the reality is, everybody's in a different place, but I don't mean that in a bad, good, best, worse. I just mean, we embrace diversity, don't we? There is difference, and I think our trick is to share, learn, bring the best of each, keep the equal up, and keep the progress. And going back to what David was talking about, the amounts of money that are pooled, I mean, it is absolutely the fact that Portsmouth has pooled more historically than some of our other areas. But again, equally there are good mechanisms in place, some more formal, some informal. And what we want to do is build to the best and not have a competition, but have a learning and sharing kind of climate and culture. And then I think, you know, and it does affect Portsmouth, doesn't it, because of the southeast component. It is different in Hampshire because there are some things that are Hampshire wide and fit very well Hampshire wide, and then there are some things that need to be more local and need to be more akin to the district and borough geographies. And at the moment, the historical CCGs didn't really fit those geographies either. And I think we've got to you know, work really closely with our district and borough colleagues so that we get that right, so that we get the real strength of the role and function and contribution of the districts and boroughs in pursuit of improving our outcomes. So, you know, I think that the reason I say all that is it can be very easy to fall into who's the best, who's the worst, who's done, you know, and it isn't about that. It's about our rich tapestry that is Hampshire and Isle of Wight. So, you know, I think we should be proud of what we've done. We're dealing with complex stuff, but I think people have worked really well together. People have really articulated what they think and why. People, I think, are feeling comfortable to disagree, comfortable to make opposing points, and that feels like a really healthy situation. And dare I say, in some ICSs up and down the country, it's kind of simpler. You know, they're either smaller or they're totally coterminous. And so we should look elsewhere and we should learn, but we should recognise that we know Hampshire and Isle of Wight, and we know Hampshire and Isle of Wight and its component parts better than anyone, and we can work around the flexibilities to get the right thing, because you know, it's the outcomes that matter, isn't it? Not, you know, the inputs are fine and we need to manage them and develop them, but it's the outputs and really getting to what are we doing and what's that looking like is going to be the business that we all want to be in.
I mean, the question wasn't really about trying to diminish that difference or that diversity, really. Just if there are, and I may be overcomplicating it, but if there are statutory health and wellbeing boards, for example, in Hampshire, and which I think there is one for the whole of Hampshire, and Southampton and Isle of Wight and Portsmouth, but if those statutory boards take a different line to what the ICP wants, for example, it's that pull and tug and how that works, that it's, or it takes a different line to the rest of the health and wellbeing boards. There's nothing, I just don't see how what we're working on that will bring that alignment.
So there are conversations with the Health and Wellbeing Board chairs coming up. I mean, that there aren't penalties or levers, financial sanctions or anything like that. But I mean, did that ever work? And really, this is a test of how can we work in our places, our sub-geographies, and how can we work together for the greater good. So it is, you know, it's going to really test, isn't it, how we work? And because you're right, you know, any one partner could sort of walk away and it would be a travesty for all of us. So this is about the building and the learning and the, you know, and I hope, you know, as we come through COVID, you know, people will be able to come together more. They'll be able to kind of pick up, build relationships again, which, you know, I mean, Teams has served us so well, hasn't it? Served us so well. But I think for some of this, some face-to-face will make a big difference. And certainly the experience of bringing the 43 PCNs together face-to-face a few weeks ago, it definitely was more powerful, more edgy, you know, more in the difficult space than perhaps a more transactional Teams approach. So hopefully, but it's a big work programme, as you identify, and this all won't be done by the 1st of July. It will be our work programme for 6 months, a year, 18 months. And, you know, just like the Health and Care Portsmouth journey that has been done over a period of time, we'll need to see that sense of journey.
Thank you, David.
I've got a dodgy mouse. Yeah, I'm just conscious. Had Helen been with us today, and she's on leave, but I think she'd be saying, Margaret, that the directors of public health have been working together to look at the similarities and differences between the various strategies for the 4 different areas, with a view to that being an input to one of the roles that the care partnership will have, which is developing a strategy, and that strategy, in theory at least, does carry some clout in the legislation. And I think that the balance they've been trying to find, working together, is to identify where there are common priorities, but to make sure that they guard against ending up with a sort of vanilla approach that is the lowest common denominator. And that is something that they're acutely aware of. And I think that's something that's why that dialogue between place, the board, and the debate within the ICP is going to be really important. Because we know from our local experience that even the finest nuances in terms of how we design and target our services can make a phenomenal difference to the outcomes. And that can be marginally different in another part of the county, but could make a huge difference to either the take up or the impact of that service delivery. So we really need to make sure that we get the balance right between the fine tuning to place and the ability to see things across a bigger population.
Yeah, thank you.
Can I ask a question? Because you alluded to the fact, David, you have been given the mandate to sign off Section 75 for the City Council. What is the process for us in Portsmouth? Jo, have you got the answer to this?
Yeah, so we're still going through finalising the Section 75 agreement. And as David said, it will be a single overarching agreement rather than 3 separate agreements as we've got currently. And then the opportunity to think about what in addition NHS budgets could be included depending on what's delegated to place. So as Maggie says, there's a number of focus groups that we're involved in that is looking at that and looking at the governance arrangements, and myself and Nikki have been very involved in those conversations. We're intending that we should be able to bring something back either to the May board or to the June board for sign off around what that looks like, again depending on where those conversations go in relation to delegation. So certainly I think in the focus groups there's been commitment to continuing with the level of integration and pooled fund arrangements that each area has. It's what that going further might look like and how that then impacts on what is delegated. So those conversations are ongoing. Nikki and I are due to meet with Jane Cole, Deputy Director of Finance for the ICS, to go next week to go through the governance and the finance decision tree that has been developed to review that. And then I think we're looking to take that to the ICS executive and then back to us as a board, as I say, either in May or June for sign off.
Right. Okay. So we've got a plan
that
we can crack on and get that done.
Yeah.
Okay. Yeah. Lovely. Thank you. Any more for David? People. Thank you very much, David. That's really helpful update. And Jo, have you got local delivery system or whatever we call it now update?
Yeah, still local delivery system, still Portsmouth and South East Hampshire. I think the board will be aware that we have had some real challenges in the local delivery system through Portsmouth Hospitals Trust and ambulance handover delays over the last month, really, from the end of March through into April, due to high numbers of COVID admissions in the trust and the impact on staffing as well. So I think not sure where we've reported it to, but we came together in sort of mid-March as a local system to agree a business continuity and incident plan to take us through Easter and out through the first May bank holiday weekend to really operate on a business continuity incident approach across the system to make sure that we were really delivering on our plan. As you'll remember, we've had an improvement plan in place from November. That's had some impact, but not the impacts we were hoping, again, because I think of COVID and the staffing challenges that were experienced throughout March and early April. So we really had to focus on what could we do differently to improve the position, recognising that it was deteriorating. And you may recall it was reported in the media very early April that both South Central Ambulance Service and Portsmouth Hospital Trust had to declare a major incident in early April. That was just over one day, and we have improved the position through then. And some of the things we've been doing is making sure that we're really clear that ED could only cope with emergencies. So we've had a really effective redirection service at the front door. So we've taken staff from the urgent treatment centres in Gosport, Portsmouth, the St Mary's one and Petersfield to work up at the front door with the ED staff to turn people around. We've improved the booking system so that people can be directly booked straight into an urgent treatment centre appointment, and also using the CAS services that are provided by the GP alliances. So again, directly booking into those services. As well as that, we've also been doing increasing numbers of staff working in the trust on wards. So we've called them discharge runners, and really supporting the discharge processing given the staffing challenges that the trust were experiencing. That's been some of our staff, some of the Hampshire, Southampton, Isle of Wight CCG staff and other partners staff as well. So there's some of the key actions we've been taking. I think Easter was in a much better position than we expected it to be through the trust, through those actions. I think it's tight again today. The occupancy has crept up, and discharges perhaps weren't as good as we wanted them to be over the weekend. But actually, I think the actions we've taken did see a significant improvement, and we saw that last week and over this weekend. So now we're looking at how do we sustain some of those actions, and particularly the ED redirection service. How can we, maintain that as we move forward?
Lovely, thank you.
To say on that. Thank you.
Thank you. Any questions? I didn't know whether Simon might want to come in about how the GP out of hours coped over the bank holiday weekend, because I know you were working there. You got anything particular about that?
It was better than previous bank holidays, to be honest. Yeah, good. Particularly good. In Portsmouth. Over the hill, it was a little bit more consistently busy, but certainly what we seem to have locally is showing to be quite robust, and it did show.
Excellent. I'm sure it helped having the sun out. It was a lovely weekend, wasn't it?
Definitely.
Joe.
Yeah, I was just going to add that one of the things I think that we've all recognised has made a difference is the really strong and proactive communications that we've done out to the public, not just around ED, but how they can access services, the right services in the right place, and also looking at primary care, but also really showing the challenges that the NHS is facing. So focusing on self-care as well, but getting stronger messaging out to people, and more simple messaging perhaps as well around what is the best place to go and to use the urgent treatment centres and 111. So that obviously we need to evaluate that properly, but it does feel like that may have helped quite considerably over the last couple of weeks.
Yes, our comms team have done a lot of work on that, haven't they? Need to thank them. Jackie.
As I said, it sounds like incredible what has been done and how effective it's been, but it's how to sustain it, because when I look at the urgent treatment staff numbers, 50% vacancy. So somehow, even if you're circulating staff between urgent treatment centres, you've still got a fixed pool. So some were at the hospital, I'm guessing some at the urgent treatment centres across the area. I don't know how they've done it. I don't know how anyone's done it. But how do we get to a sustainable position? And my last little comment to add to that, as I saw in one of the reports, we're thinking of increasing the salaries, which seems, do you know what, I'm all for that. If we've got it, pay people their worth, that's for sure. But I guess that needs to be across everyone in the urgent treatment centres to prevent just nicking each other.
So, yeah, so it is a complex piece really, and so the pay more is something that PPG, who provide the St Mary's Urgent Treatment Centre, have been looking at. They have had a particular challenge in recruiting and retaining substantive staff. So a lot of their staffing at the moment is on agency and bank, and that's probably quite unique to them as a service, I think, and it's something well, no, that's not fair, perhaps, because lots of our NHS services use agency and bank, particularly at the moment. The treatment centre has relied on a cohort of agency staff for quite some time, and I think with COVID, that regular agency workforce has been more difficult to get and to manage. So that's where they're really feeling that pressure. So we're continuing to work with them to look at how they manage their staffing and what shift patterns they can put through, because obviously, as you'll be aware, we've had to reduce the opening hours of the UTC down at St Mary's to 8 p.m. and we really want to work with them to get it back to 10 p.m. like Gosport. So in terms of sustainability, we've set up a joint operational team across the 3 urgent treatment centres, so Gosport, Portsmouth and Petersfield, and this was operational sort of from December, but it's probably stalled a bit, if I'm honest. We've re-established that as part of the work we've been doing around ED redirection, and the aim of that is to do more of that rotational work and to look at how they can support the recruitment across the board and work differently. So it's early days, but that's how we're looking at supporting them to create some of the capacity in the workforce that they need, and different roles that could perhaps work across a number of units.
Thank you, Jo. Linda.
Yeah, and I think we just have to be mindful of, out of hours rates is one thing, but when you're paying in hours rates that normal general primary care cannot match, that we would potentially create an unknown problem there. We are, I know, having discussions, aren't we, with the Primary Care Alliance about making jobs which put people in practices for a number of sessions and then gives them the freedom to do sessions in things like acute visiting or the CARS. But the concern is if the out of hours providers start paying in hours work rates for in hours work, should I say, primary care cannot match that.
No, Linda,
Jo,
sorry, there's no intention around that. I think there's a particular issue in St Mary's and around how they, as an independent organisation, can look at improving their recruitment potential. And as you say, the work with PPCA is to look at, can PPCA offer sort of become a bit of a locum agency? Can they offer salaried posts of some sort, working with PCNs to offer additional sessions into practices? And that's really to look at how we make Portsmouth a really attractive place to attract GPs of all types and all ages, really. So yeah, those conversations are ongoing, but very mindful that we need to make sure that there's not unintended consequences of that, because you end up increasing the salaries. That's not where we want to be at all.
Lovely. Thank you. I just wonder if some of these plans should be shared more broadly with the board, because I know we have had discussions about them. So perhaps either at a development session or another board meeting, we could share some of those workforce plans as they're coming up to better state. Does that sound useful?
Of course. And there's certainly a primary care development plan that we've been working with the primary care commissioning committee on, but we could share it with the board.
It may be useful to share. So thank you very much for those updates. I think that's all very useful to know, and we do need to pass our grateful thanks back to everyone who has been working so very hard on all of these plans, but also in the frontline delivery. So thank you all very much. So item 7, finance and performance reports. We've got Nikki presenting the finance report, I believe.
Thank you very much, Elizabeth. So hi everyone. So what I'm presenting to you today is the month 11 report, but obviously we are in the process of closing our month 12 accounts, so I'll give you a quick prezi of that as well. So as you can see in the finance report, around our KPIs, as at month 11, we did still have some of our KPIs that weren't quite where we wanted them to be. So they were around cash utilisation, our debtors and creditors position at percentages above our target. Really pleased to sort of confirm that as at year end, we did close with a cash position in line with the national expectation, and equally the issues that we saw with our partners at the local authority in terms of them being able to release invoices for payment is now resolved. So all of our edged debtors are cleared now with the local authority, and we're not anticipating any future issues with that. Now we've ironed the issue through. In terms of creditors, our major creditor here is NHS Property Services, and this is around disputes on voids around St James's Hospital in the main. So we are in negotiations with them, final stages of negotiations now, in order to settle that position out. And we should see what will look like a deterioration in creditors' position as we are going through a major tidy up of the ledger, and we have some temporary resource now working to clear all aged creditors. What we'll see over the coming months, just to prepare you, is a deterioration most probably through our BPPC figures as we clear some really historic invoices, but an improvement on our creditors' position. In terms of closing the year out, we closed the ledger last night at 5 o'clock, and we are just now going through preparing all of the schedules, etc., that prepare the annual accounts. We have closed our position in line with our projected break-even position, and we will, of course, be able to share those final positions with you in draft format in the coming days. So the initial submission of those accounts is due by 9 AM on the 26th of April, which is next Tuesday. So we should shortly have that first draft of annual accounts and report to share with board members. That was all I was going to say, unless anybody had any specific questions.
Questions? Beautifully. Oh, Jackie.
Just a quick one that I probably don't understand. And looking at the reserves and contingencies, it says minus 3.8 million.
Are you looking on, 1 second, Jackie?
Summary of the financial performance, reserves and contingencies, I guess for month 11, just above the in-year surplus, reserves and contingencies minus 3.8 million.
Oh yes, so that relates to the way in which we've been transacting SDF across HSI and the CCG this year. So rather than giving us our allocation for SDF, significant amounts of money have been transferred via invoice, so it looks like income to us rather than an allocation, which has made our reserves look like we have a negative budget, which looks odd and presentationally, but it's just a technicality in the way that so the system money now goes all through HSI CCG, and then we draw that down into our CCG via invoicing.
I think so. As long as you understand that it's not us in a deficit position so far as reserves and contingency goes, that's the main thing. We've got what we need to do what we need to till we're not here, sort of thing.
Yeah, certainly not deficit, no, Jackie.
Right. Any other questions, comments? Thank you very much, Nikki, for that. So if we can go to the performance report with Bernie now, please.
Thank you, Elizabeth. Just to pick up on a couple of things with this. So as Jackie pointed out earlier in the conversation with regard to COVID, we do in the tables, in the headline measures, report an absolute red or green delivery of the metric compared to the national targets. And that is consistent with the methodology that is being applied across the ICS. However, in the summary sort of alert, advise and assure section, we do apply locally some amber scoring to recognise, where things are either improving or getting close to or are hovering around those targets, and recognise, say, more closely the local position. So in terms of where we are from a performance perspective, the alert, advise, assure section is based upon the January performance indicators. The more recent indicators were published on Maundy Thursday. In terms of where we are, as we've discussed already, the ambulance handover position remains incredibly tight as part of the urgent and emergency care flow. However, our number of 52-week waiters has come down from the 365 reported to 325 this month. Our 78-week breaches has come down from 42 to 36, and our 104 waits have gone down from 7 to 4. All of which are heading in a better direction, and similarly our 6-week diagnostic weights has improved from 68% to 74%, so an improved position in terms of those key metrics to that reported in the written report. Sorry if you can hear the drill that's just started behind me. And the other metrics, really, there are no change. So the areas of focus for us continue to be how we look at improving the diagnosis rate for people for dementia, which, as we know, has been impeded by the pandemic most significantly, and also IEPT access rates, which is one, despite the continued reporting of increases in mental health challenges, we remain, in terms of a population, a lower access rate to that service than the national target. The waiting times for all of those services are really good. It isn't because people are having to wait a long period of time. It is just introducing people to those services in the first place. That's all I was going to say specifically on those metrics, because there is very little change to last time.
Thank you, Bernie. I'm seeing Linda's got her hand up, but I'm going to jump in and just say, how many other areas have a service like Positive Minds that we use very much as our first port of call instead of IAPT? I know IAPT has lagged in access. It's been a problem for forever, but my gut feeling is, from patients I have contact with now, many more have touched base with Positive Minds and get fixed or supported sufficiently for the moment through that. Do we have any comparators to understand that?
No, it's something we can look into with the commissioning lead to see if where we are in terms of that kind of service provision. But it certainly is a sustained impact, I think, as we've said, on our access to IAPT. For the better, one would say.
Absolutely, absolutely. I also, it will be interesting to see, and our recovery, our actual recovery has gone up, because a lot of the work that Positive Minds do is prepare people to go into therapy, and I wonder if that is contributing to our improved recovery, that people who access Talking Change better. It is such a, I only hear very good things about the service. Linda.
Yeah, so you stole my first quote. That was my first point completely. I think you were reading my mind. Also, we've got social prescribers who are picking up some of that lower level stuff as well. But my other thought is, are employers putting in more help because of the pandemic? I know certainly the NHS stepped up what they were offering in terms of support for employers, and I wonder if other people have as well. And that obviously would then impact if they're accessing it through work. Just a thought.
We'll see.
I was just wondering, do you have a way of finding that out? Is that something in the public health arena and the LRF with employers?
I'll follow up and see what we can find. Jo's got her hand up.
Yeah, I think some of the mental health groups and the local mental health strategy, there was quite a strong piece with employers in the city and again at ICS level. So there's definitely something we could look at, and we could also look at the comparison. And I'm not sure, there are a similar service in Hampshire, but I don't think it's the same as Positive Minds. I don't think it's, yeah, so how those two are impacting would be useful to find out. So we can definitely take some of that back to the commissioning team and ask them to look in it, and because there's a lot of work around mental health at the moment, no wrong door, community mental health transformation. We could look at it in that and see where we're different, where there's learning, and how we could share that.
And also we're piloting mental health practitioners in primary care at the moment as well. Yeah. So there's lots going on, and it's just useful that we can understand what's making the difference.
Yeah.
Margaret.
I think I agree with it. We're not measuring the right things when it comes to mental health in the city. That's basically what we're saying. But I did want to make a less serious point. If we're communicating publicly, how helpful is it to have 4 pages of a glossary explaining acronyms? Just isn't going to be at all digestible by the public. So I mean, I think there may be. I mean, I know I'm talking to the wall in some ways, and there are limits to how we can change it, but some effort should be made to try and make this easier to read, because even if it means putting some of the glossary in earlier in sections, rather than having to go to, before you get to anything at the end of the report, you just won't do it, will you? You won't go through 4 pages to understand what's being said in the earlier pages. But yeah, just a point.
Difficult, isn't it? Because we've asked for a glossary in the past. So, yeah. It's a no-win situation, Bernie. Having said that, I thought some of the glossary was really quite good, because it really explains the stuff very straightforwardly, which when you just spell out the acronym, you're none the wiser. So balancing act, difficult one.
Yeah, it is whether you can sectionalise it in any way. I mean, so make it slightly more digestible than it currently is. But yeah.
Okay. Thank you. Any other questions on the performance report, or shall we move on to the improvement programme? Okay, Bernie, more from you. Thank you.
And this is a continuation of a theme from previous months. As Jo has explained, since November, we have really focused our efforts into the urgent and emergency care programme, and are continuing in that business continuity approach through until early May. So in terms of the wider improvement programme, although there are efforts to continue with some of that work informally. Our formal reporting covers off the steps that we are taking to see some sustained changes and improvements to our urgent and emergency care, which Joe's already covered off in sort of the LVS update. So I wasn't really going to go over that in any further detail either, unless someone's got a specific question.
Linda has.
Sorry, it's me. I was reading it today and I was looking at the RAG ratings, and the one that's bugging me is the ambulance rapid release pilot, because there's a whole update about basically not only did we not hit our target of reduction, but we've actually gone the other way. And then right next to it says green. And I would just challenge that, because our target was to halve from baseline, and we didn't halve. In fact, we went up again by half. So yeah, I'm assuming it's green because the rest of the programme is running to track, but it just doesn't read well. And if I was a member of the public looking at that, I'd be thinking, what on earth? Yeah.
Yeah, and it is a balance, I think, between completing the agreed steps and the agreed steps having the intended impact. And that is the challenge.
Oh, you've gone on mute, Bernie.
Oh, sorry. Can you hear me now?
I can now, thank you.
I don't know how far I went. So there is that fine balance between delivering the agreed steps and the agreed steps having a sustained impact. And it is a challenge.
So the green, it just relates to the process having been completed.
Yes.
And we don't have an outcome measure, which would actually just see a sea of red for last week.
Yeah.
Whether we should then, that would be my challenge. Should we have one for have we done what we said we were going to do, and one for has it had the desired impact? Otherwise, it's all a bit meaningless, I think.
Thank you. Then we've got Graham and then Joe.
Thanks, Elizabeth. I just wondered, I noted around emissions avoidance, we're using the Lightfoot risk management tool, and I just wondered whether that was showing any signs of kind of adding any value to the work that we're looking at, or whether it's too early to say.
Can anyone answer that one? I'm the only bits of working with Lightfoot data I've seen, it's not been particularly helpful. But I don't know whether Bernie knows any more, or Joe.
Yeah, so I think we've had some limited data on some practices. They tended to be in the southeast. I think when we've looked at some of the Portsmouth data, it didn't pull very much through. Whether that's an issue with system one or not, I'm not sure. But I think where we were able to get some of the data, that has helped, meant some of the practices have been able to look at that and change some of their care planning approaches. But it hasn't been universal, and I think the challenge for us was always this was a new thing coming in when we're focusing on our population health management system, which again is being rolled out and in the very early stages of being developed. So it perhaps hasn't been as useful as we'd hoped it would be across the board, but for some practices where we did get some data, it has been quite useful.
Thank you.
Jackie?
I just wanted to hammer home Linda's point that I really think if the green ratings relate to getting processes done correctly, that's not terribly helpful, and that I'd love to see something that shows the outcomes, which is what we're all about. Outcomes would be much more helpful, or both. Don't mind if it's both. But it's a bit disingenuous to have green when we know the outcomes aren't actually meeting or aren't what they should be. That's it.
Thank you. Joe?
Yeah, I agree. I think that so the report is designed to show both the actions that are being taken and the indicators. So slide 3 is the impact. What I think we found, in part because of the challenges of COVID, the COVID admissions, the impact that's had on the trust, the impact it's had on them managing the bed stock and turning the bed stock over quickly enough to get people through. that has been a particular issue, as alongside the staffing challenges in both SCAS and the trust and in the community as well. So I think that's why we're seeing the actions that we've taken have been we've delivered the action that we said we were going to, but we haven't had the impact. And that's what slide 3 shows. Those key dials have not had the change that we wanted them to. And interestingly, on this slide, there's usually an arrow that says whether that's improving or deteriorating. It's kind of not there at this time, but I do think we've had some significant challenges that mean the actions we were expecting to take haven't had the impact that we'd hoped. So we continually review, but yeah, take the point, and we can take that back into the Portsmouth South East Tants team, can't we, Bernie, that it's not clear enough really where we've done something but it hasn't had the impact that we wanted. So yeah, we'll take that back. Thank you.
And I suppose the follow on from that is, and it's not had the impact, so this is what the next steps are.
Yeah.
And where do we go from here? And some of that, maybe we give it another 3 months.
Yeah.
You know, we don't expect everything to work straight away. I was in a meeting earlier on today, and there've been lots of these changes we're looking at, but the education hasn't been delivered to chunks of the workforce. And if they don't know about these services, they can't use them. So it takes time, and we are aware of that. And I think we do have to give it time for some of these things, but let's be clear about it and up front. That sounds a really good way forward. Any other questions or comments about this report? There's so much going on, but yeah, thank you, Bernie. We've just given you more homework, but much appreciate the efforts you've gone to. Okay, thank you. So quality and safeguarding report with Karen.
Yeah, thank you, Elizabeth. The report we've got is from our meeting in March. So I think the format is fairly familiar to people now. So if I just go through it briefly, the first few pages are system risks. There's no significant changes, I don't think, there. We're all aware that there's unprecedented levels of demand and intense staffing challenges in the health and care system. And whilst we know that there's a lot of actions being taken, the quality risks still remain the same, so they haven't changed. Then we move on to the local summary and highlights. So there is a number of innovations. A lot of those are around training and leadership, but they're there for information. And then the next few pages are around specific risks. So they do overlap with the system risks, but specific risks that are relevant to Portsmouth. So there's quite a number there. And again, not a lot of change. The one that perhaps has changed is the one, at least we did change it last month, which was the one around BPAS, which was the early medical abortion at home service. The quality team had been working quite closely to try and change the position whereby people were being sent pills in the post and not having that initial consultation. And this was implemented during COVID. And we were trying to change it because it was meaning that there were some incidents where people were having late terminations. We thought that there had been a change, and we've moved the risk from amber to green around that, because we thought the government was going to take the position whereby women did need to come in for their first consultation. However, that's been reversed again, and the law is going to continue and allow people to have pills via post and have termination at home. So whilst we did change it for last month, the position remains unchanged actually. So that's the only thing on the local risks I probably wanted to highlight. Then we move into, there's the safeguarding report, and a couple of things from that just to pick up. I think the UM's GP hub has commenced. That's linked to the Portsdown practice, and they're offering appointments every Tuesday. Portsmouth currently has 41 UMs at the moment. There's also a concern raised via safeguarding that around digital notes, because patients will be able to access their GP medical records, and this includes being able to access children's files if the parent has parental responsibility. And so we're concerned if it introduces risks of domestic abuse survivors being located and looked after children in placement being located. The issue has been raised nationally. CCG are discussing the issue with local hospitals regarding redacting addresses from letters sent to GPs. And named doctors across Hampshire have been developing a training package and will be delivering a webinar this month to try and reduce that risk. And I think the other thing on safeguarding is around the Department of Health and Social Care have commenced a public consultation on the Mental Capacity Act Code of Practice. Liberty protection safeguards will replace DOLS, and CCG will become the Liberty Protection Safeguard responsible body. So they will authorise the arrangements for the amount to deprivation of liberty to enable the care of treatment. This consultation will run until the 7th of July. The report then goes on to a number of deep dives. So we've got a deep dive around the Practice Plus group, specifically around the quality impact of the workforce issues. And I think Joe's earlier talked about they having difficulty attracting permanent staff, and that continues. And they're reduced opening time, so that they're closing at 10 instead of 10, closing at 8 p.m. instead of 10 p.m. to help mitigate this. We learned today that PPG have just successfully increased their staffing salaries in line with NHS rates. So that might have an impact, but at the moment, obviously they haven't seen that. What else around them? They have introduced a safer staffing procedure, which includes escalation process and the ability for the UTC to book adult patients who have been clinically assessed as low acuity into appointments the following day for reassessment and treatment. However, 50% of those people weren't returning, and our discussion in March, we talked about our concerns around this 50%, and were they then seeking treatment at ED or in other places, and so was that working? We were looking for an audit, but I think that's now been superseded because of the ED redirection plan that's happening. The next deep dive was around SCAS, and this was the we wanted a deep dive because of the CQC safeguarding focused inspection, and where they identified that there were numerous areas that required improvement, including governance and training. But there is an extensive improvement plan that's been drawn up to address the issues identified. So there's not a lot else to be said about that. We reduced that risk. That was a risk of amber, and we reduced that to green because of the work that's been done around that. And finally, there was a deep dive into the asylum hotel, because I think last month I discussed the fact that we were concerned that the health needs of these people weren't being met. There's currently, I think, about 90 residents in the home, including children, but the quality and safeguarding team have set up and support an operational meeting that happens weekly between frontline staff in the hotel and local services, and I think we're fairly comfortable now that there is a lot of work going to make sure that the needs of these people are being met. So they were the three healthcare the deep dives, and then the last few pages are just describe the urgent and emergency care patient safety impact that was delivered to the system, and it was here for information for us, but I don't think it's anything that we're not particularly aware of. That's about it, I think, Elizabeth. Thank you.
Thank you, Karen. Right, any questions or comments for Karen? Graham.
Thanks, Elizabeth. Just a couple. I think the comments again come through quite strong about the workforce plans in terms of providers and primary care workforce. And I think, as we said earlier, and I think Joe said, I think it would be handy if we were able to have some sight of the thinking and plans of those, either at a development or board session, because they seem quite pivotal clearly in other decisions about opening times and issues connected to that. The other thing I just want to flag is, and I think the report makes the comment itself, that it was incredibly sad to read some of the serious incidents involving the urgent and emergency care and some of the timings on some of those, and particular peaks in, I think, October and December. I think 10 of the 14 incidents are in that time frame. I see there's a thematic being done on the October. I just wondered if we've got a broad sense of timescale as to when that will report back.
I'm sorry, Graham, I haven't at the moment. I was aware of that thematic review, but we didn't talk about timescales. But I can get that for you.
Thanks, Karen.
Jackie.
That's exactly what I was going to ask Graham. I fully support if we can get some timelines. That'd be incredibly helpful for something that's been incredibly sad. It makes it very real when you read these sorts of stats, and they're real people. The other thing I wasn't sure about was in the PHU paediatric unit, where young people with behavioural challenges are appearing there. There hasn't been a deep dive on it, but it was one of the comments as part of the safeguarding report. And I wasn't sure about what was the solution for where they go. I'm looking puzzled, Karen.
No, it's fine. It's just we've been asking for a deep dive on that, particularly because that's been an ongoing thing. We haven't had it yet, and we're chasing it really. I think we've got one person there at the moment that's needing enhanced support, and we haven't managed to get a tier 4 bed for them. So we still struggle, but we are asking for a deep dive, so there will be a deep dive into it.
Thank you. Sarah.
Yeah, just to say on that piece, we have done some work looking into the children who are then placed on a ward for a length of time longer than we would want, causing quite significant pressure in the wards at QA. Anthony Harper has led a piece of work looking at some of the kind of journeys, I guess, of those children who end up on the ward. The challenge, as has just been identified, is the move on and the lack of capacity in tier 4 beds across the country. It's a national challenge, and we hear local authorities are now continually placed alongside health colleagues, having to provide makeshift care arrangements for those children to move them out of hospitals where clearly their behaviours and their traumatised behaviours are challenging those children who are physically unwell. But yeah, it's a piece of work that has kind of been started on a small scale by Anthony, so we need to make sure that feeds into any bigger piece of work that we do.
Thank you. It'd be really good to hear the feedback, and if there is any deep dives, it'd be great to see that, just so that we can perhaps change the outcomes for these young people. Thank you.
Okay. Thank you very much then, Karen. That's really useful. So we've received that report. Item 9, Governing Board Assurance Framework and Corporate Risk Register. Justina, did you want to talk to this?
Yes,
or
please, Elizabeth,
Yeah.
okay. So it was really just a bit of a reminder to the governing board that our strategic objectives changed at the end of last year, as a result of which we changed our governing board assurance framework. I'm not going to go into detail on the GBAF. Suffice to say that there is a subgroup of the audit committee that meet, which is risk group, that have looked at the GBAF at the end of March. And they asked for a couple of additional risks to be put on the corporate risk register, which the governing board members will find under CR 008 and 009. So we'll do some further investigation into that. You'll see that those tie back in with some of the stuff you've been seeing today and hearing today around performance, etc. The risk group meets on a monthly basis. We'll keep an eye on that. But at the moment, there's no significant change to GBAF scores. But obviously, once things start to move around, you should see some changes there over a period of time, either things settling down and becoming less risky or actually increasing. So I wasn't going to say anything more than that unless there are any questions.
Thank you. Any questions for Justina? Graham.
Thanks, Justina, and obviously I know I sit as part of that group, but I was just going to say I think one thing we just need to look at is I noticed looking at the scores today that like ambulance handover, which I think is CRR01 on the list, so the first one on the list, is scoring a 16 on the risk register, but 20 in the QSEC report. So I think we've got some things not quite aligned, and certainly I think from reading where we are at the moment, probably the 20 feels probably the right place it should be at the moment, but I realise we can have a debate about that at a different time.
Thank you.
Thank you. So yes, that goes back to the risk group to get that aligned. Thank you very much. Okay, so we've been asked to receive this report with that amendment and hand it back to the risk group to continue the work on that. Thank you very much. And we now move over to Sarah. And is Anthony joining you as well? Or is it just you, Sarah?
No, he's deserted me and gone on holiday. But I will give him the credit that he did do all the work in preparing the presentation. So yes.
Okay. So over to you.
I will find the presentation and share it on screen. Okay. So hopefully people can now see. Go to slideshow.
Yes. Got
Lovely.
that up.
Okay, so obviously this relates to the Ockenden report that was the review relating to Shrewsbury and Telford Hospital Trust. The first report was published back in December 2020 and was the result of the review into the maternity services in Shrewsbury and Telford hospitals, following some significant concerns over a number of years. And that report issued 7 immediate and emergency actions that required address, and they're listed there, so I won't run through them. The final report has now come out March 2022, and that outlines those large wide-scale failings that relate back to governance and quality of care. And the main messages are that the Trust did not invest, learn or listen to families. So the key pillars for those immediate areas and emergency actions are around staffing, a well-trained workforce, learning from incidents, and again, that listening piece and hearing that feedback. And the report highlights 15 themes for maternity services to review in every area. Again, they're outlined there. I won't go through them all now. So the final report identifies those measures, but then we're written to as a Portsmouth CCG board having a duty to prevent similar occurrences here, but to review and agree actions to mitigate any risks that we identify. So that piece of work is then undertaken and a self-reported compliance by the local maternity and neonatal services is issued here, and we can see some good measures and some good results, but also some slightly more concerning ones relating to the monitoring of fetal well-being, risk assessment throughout pregnancy, and that informed consent piece. These relate back to January, and conversation with Anthony last week provided reassurance that actually these were continuing to improve, and if we ran that kind of report again now, we would see those measures improving. So managing of complex pregnancies has been a priority for the LMNS, and funding and a spec is in place for a new service across the ICS. there's been an increase in that senior management team to oversee processes. There's been the appointment of the new deputy director of midwifery, deputy director of midwifery, governance midwife, and a stronger clinical leadership team who are all overseeing the progress within Portsmouth. So we also have BadgerNet, which has been implemented across maternity services. With any new IT system, you get glitches and horror stories, but we can see BadgerNet really starting to improve that risk assessment through pregnancy, and conversations with the health visiting service are really highlighting an improved kind of transfer of information and communication in that area. So in terms of next steps, the biggest issue, I guess, for us locally, we've already heard this in a number of other kind of conversations today, is around staffing and staffing pressures within the system. But those working within the midwifery service, we hear about good levels of job satisfaction and a really strong focus on staff wellbeing, which is really positive for us here. There will be further, that review in January will be repeated, and we will continue to look at the improvements made here. What we also need to note is that we are also awaiting a report from East Kent. They're likely to be similar messages, but additional learning for us to take forward. So the next steps will be further assurance in terms of the PHUT. So some additional insights visits are planned in coming months, which will review the quality and the governance. But it's a moment for us to take stock. We don't have to formally benchmark, but actually the piece of work we've done will quickly show us the progress being made by that leadership team that's in place and across the services. We've got, as I've said, the insight visits planned. The capability and capacity review is planned with outcomes later on this year, early next. And it's that piece around that wide ICS wide need to agree accountability in housekeeping with regard to the commissioning, the transformation and assurance going forward. We know we're moving in the right direction, but we need to keep a focus and an eye on this to make sure that that journey travels forward. Stop sharing.
Thank you very much, Sarah. That feels to be quite reassuring. Have we got some questions? Jackie?
Yeah, that does feel reassuring, but yeah, we'll see. I was curious that, especially around staffing levels, I know that these people will be very committed to what they're doing, and it's good that their well-being is really also front and centre. But there's a gap of about 17 whole-time equivalents. That sounds like a big gap. Are there any plans to recruit, or how do we do it, or how do we work clever to fill that gap?
It is a big gap, Jackie, and it's a big gap nationally. I think what we've seen is that actually just the whole offer in terms of education and bringing new people through the system is a challenge in terms of the university offer. And it is a challenge for us in terms of that broader workforce piece. So I think it's something we need to look at in Portsmouth as to how we do target these specific areas where we know we have challenges recruiting into our workforces in Portsmouth. But yeah, I think you're right. The counter that we have is that those who are now working in that part of the service are very well supported, and there is that role specifically targeting that well-being, and we have heard very positive feedback around job satisfaction, but it doesn't compensate for the current gap that we have in terms of those roles.
Absolutely, thank you. And could I ask very quickly, there's another one again from the performance report, that the percentage of women accessing specialist perinatal mental health services is quite a bit off target. And I'm guessing this also loops in with this kind of work in terms of maternity services. Again, is there any plan to get that back where it needs to be?
Now that I don't know the answer to, so I will make a note, Jackie, and I will come back to you on that and let you know.
Thank you, Amy. Thank you.
Good. And along those lines, Jackie, I think there is something around for the city, again, young women are accessing support elsewhere, rather than perinatal mental health. And there was quite a weight on the perinatal mental health services. So I think people were getting help, like Positive Minds, Talking Change, those things, which may mean that they haven't access to the specialist services. I don't know for certain, but I know of a couple of individuals who've done that. So I think we've got, different things available possibly.
Yeah, it's something it feels like we should need to tell that mental health story, as to why perhaps acute services aren't so needed, because there may be alternative, the lower preventative end or that lower middle end. We're not telling that story, it seems to me.
I think we need the facts, but because we are making suppositions, and it's from experience rather than data. But yes, I would agree, it's worth looking at that data.
Agreed, thank you.
And certainly if Sarah is able to get some more information, that'd be great. Any other comments or questions? Yeah, that's great. And I have to say, I'm nicely assured that we're on the right track. The right things are going on. And so thank you to Sarah, and if you can pass our thanks on to Anthony Harper for the efforts he's gone to in that. Thank you. So minutes of other meetings. We've got Primary Care Commissioning Committee from back in November and Health and Wellbeing Board in November. Have people got any comments or questions on those minutes? Quite old. We've discussed quite a lot of things, the more recent to those. Okay, so as long as you've noted them, we can move on. We have a date and time of next meeting in public, which is currently scheduled for the 18th of May. However, we may be using that actually as a development session, bearing in mind some of the conversations we've had today with a final Portsmouth CCG board meeting in June. But it's a case of watch this space. We will be keeping everyone informed as time moves on. So thank you very much. And Jane, can you end the transmission?
Yes, I'll do that now. I'll let you know when it's done. Thanks.
Thank you.